Uh, so I'm Dr. Punit. I am a additional professor in pharmacology. I've been in this institute since 2013 and now maybe because of some reasons we are not seen very visible in the clinical side, but yes, behind the scenes we work, like running the pharmacy, hospital pharmacy, running the ADR monitoring center, and where this, you always report that pharmacovigilance wala component and the assessing the quality of the medicines which are available. So primarily these are the administrative activities we are involved into. And prior to this, I was taking care of IT also. So the e-hospital which you are using was initiated during my tenure, and right now somebody else is taking care because of some other reasons. So we can have a discussion regarding the safety aspect of the drugs. We can have a discussion regarding the IT aspect of antimicrobial stewardship program, and we can always have a discussion about the medication errors which you can avoid or which can be prevented. So my focus of discussion will not be more of theoretical, although the presentation may look like theoretical, but we are going to discuss only the practical aspects which are relevant for you people. Starting with this, what exactly are we talking about? We are talking about stewardship program. Definitely write these. Everybody knows, and we are not going to discuss it any further. What exactly this means? Right diagnosis, not bothered. It is the clinician's responsibility. Until unless it is required that we pitch in for diagnosis. So it is the responsibility of the clinician. So we will not discuss get into the diagnosis, how they diagnose the disease. Then comes the issue of empirical therapy and the definitive therapy. Whether the therapy has to be given, the therapy has to be according to the spectrum of the drug. Now this is something which the nursing staff can also pitch in. Empirical therapy, usually it is going to be clinician's decision. Nowhere we are going to be part of it. Once we start talking about the definitive therapy, you can always discuss about in three aspects. Whether the drug which has been prescribed is going to cover gram positive, gram negative, or anaerobes. Now the question comes, how are you going to get this information? Whether this particular drug is active against gram positive organisms or gram negative organisms or anaerobes. The best reference document which you can access, can anybody name? Now this is specifically about pharmacology. It was discussed, and it is discussed with second prof students and second year nursing students also. But everybody forgets later on when they actually start practicing. Which is the best reference document for getting information about a drug. I'm not talking specifically about antimicrobials. I'm talking about a drug, any drug. Somebody will say Google. We Google the name of the drug and we get some information and we use it. Or somebody who has been using it more frequently, who has been trying to get information about the drug, would talk about some websites like RX Factor, something like that. There are many drugs, such sites which are available. All these are not regulated sources of information. The best source of information is the prescribing information or the package insert. पेपर नहीं निकलता ये लंबा सा, जिसमें छोटा छोटा सा कुछ लिखा रहता है, जिसका या तो पहले तो जब आप स्टूडेंट होते हो तो हवाई जहाज बनाते थे, अब जब थोड़े से बड़े हो गए हो तो आपको लगता है ये क्या है, इसको चलो या तो अपने हाथ साफ कर लेते हैं या फिर उसको वैसे ही फेंक देते हैं. But that is the best source of information. Now whether it is available online or not, yes, it is available online. But you have to use the right keywords. The right keyword is prescribing information. It is not the package insert. It is the prescribing information of the drug. Specifically for antimicrobials, you are getting a drug, and the first thing that it will talk about is the spectrum. Whether it covers this drug is active against these bacteria. Now, should you be cross-checking it? Do you have the authority to cross-check whether the prescriber has prescribed it for the right infection or not? Can you do it? I leave the question open and the answer also open. But yes, this is the best reference document which you can always use for this. Then comes the pharmacological point of view. This is the academic slide. When we are selecting the right drug. What we think when we are proposing the right drug, whether the drug is going to reach the site of infection or not. That is the first question. whether there are any other comorbidities which are there or not, like renal or hepatic functional compromise or any other disease process or concomitant illness which can be affected by this drug. The simple example I would like to give, fluoroquinolones. The family you know about, that quinolone family, ciprofloxacin, moxifloxacin and all those drugs. They prolong QT interval on ECG. With prolongation of QT interval on ECG, the patient has got a tendency to develop arrhythmias. Now, if we are not giving it and not monitoring the patient in these situations, definitely the patient can land up in any kind of arrhythmias. So whenever we are, so these are the very few specific points which are required for some classes of antimicrobials which we need to think. And since you are the first point of contact with the patients, next point of contact is the resident, third point of contact is the physician, you should be able to identify a specific list of ADRs which are possible with any drug. And if you are posted in ICU or intensive care units, these are the things which become critical. And then the drug-drug interaction potential. Now this is something usually a physician or a resident checks, but he may not be able to check all the drugs. Now if you are supposed to check the drug-drug interaction potential, what are the sources? What are the reference documents? Are they available online? Are they available on smartphones or computers? So that you can easily see whether this is happening or not. This may or may not happen. Free Medscape तो सबको मालूम है ना? Medscape के ऊपर ही drug interaction checker रहता है. The tabs, the buttons जिसमें आता है ना, वो Medscape में diseases, diagnosis, उसी में ही drug interaction checker रहता है ऊपर. That you can always click, put the names of the drugs. There is no limit of the number of drugs which you can put in, and it will give you the results. The results will be in color coded. This is according to the severity of the drug-drug interaction which is possible. So again, you can use Medscape or drug interaction checker. One key point about Medscape is, since it is a US site, it uses the name of the drugs which are used in US. Like paracetamol, you may not find it. It is acetaminophen. So if you are not able to find a drug, look at the name of the drug which is used in that regulatory region. But it is a very reliable source of drug information and checking the drug interaction potential. Then comes the right dose. What we see and what clinicians see as the renal functions, depending on the elimination, hepatic functions, other comorbidities like CHF patients. We discuss something about QT prolongation. Or there could be any other disease we are going to discuss. And the drug-drug interactions according to the which can modify the dose itself. Now from here your role starts, actual role, the route of administration. Although the route of administration usually is on the primarily, since we are in the hospital setting, primarily it will be IV for most of the antimicrobials. But yes, some drugs can be given orally. The IV to oral switch, when it is happening, whether it is there documented or not, and whether any other route which can be used. Like example, I would like to give for specifically for orthopedics, osteomyelitis, difficult to treat infections. Very prolonged antibiotic use is required for managing the bone infections. Can we find a solution for this, which is called as innovative thinking? Let us say a patient has been a joint replacement, or he needs a graft which has been placed in the bone. A joint replacement, for example, bone cement लगाते हैं. Bone cement के अंदर can we put in some antibiotics? We are doing it actually. We are doing it, but we are doing it only for a couple of antibiotics. So that is called as innovative thinking. Do we actually get who is posted in orthopedics? Anybody who has worked on bone cement? That is why you are able to answer. Okay, do we get commercially drug impregnated bone cements, or we do it in house? Both. Okay, so there are only a couple of antibiotics which are available. So at this point of time, this is just kind of innovative thinking. Like you remember Dr. Tarun? Dr. Tarun Goyal. We did a project with him where we impregnated 2 antibiotics in the bone cement, and Again, the same continuation we are doing it for the other two antibiotics. So the innovative thinking involves local application of antibiotic so that systemic exposure is minimized. So this is where you can always use your heads. You can discuss it with the treating physician whether this is a possibility or not if you want to treat a localized infection. I am 100% sure that you will be happier when you use your CNS, and nobody stops you from using your CNS and having an open discussion with anybody. So until unless आप अपना CNS नहीं लगाओगे तो you will be just becoming like a follower and boring. Okay. Next comes the issue. Again, this is a critical issue which is relevant. Whether the drug has to be given as a bolus injection, or it has to be given as a continuous infusion. This is something which is default setting is prepare the drug, either give it over 3 to 5 minutes, or put it in the fluid and give it over 30 minutes. Or 30 minutes, or if it is the 100 ml का जो act है, give it over 30 minutes. This is the usual standard practice. And these are primarily the default setting which may not be right according to the drug. Some drugs require bolus infusion over 5 to 15 minutes. Some antibiotics, we are talking about antibiotics. Some antibiotics require to be given over 3 hours. Now, the difference is because of the antimicrobial pharmacodynamics. Some drugs have got concentration dependent killing, where peak concentration is more important. And for them, it is the bolus infusion, which is relevant. Example is aminoglycosides. Some drugs have got an antimicrobial kinetic dynamics, which is concentration dependent killing, where the time for which the concentration is maintained above MIC, it is more important for killing rather than the peaks. Example is the whole beta-lactam class. The penicillins, the cephalosporins, the vancomycin, the carbapenem, this whole class, they have got they need to be given over continuous infusion. So do not follow, basically just cross-check the dosing way of administration. Now again the question comes, from where are you going to cross-check? It is the prescribing information. This is the reference document which you can always use. Then another issue is all about the diluents which have to be used. Whether it is normal saline, whether it is ringer lactate, whether it is which diluent has to be used. Now for antimicrobial, different is required. There are a few exceptions which are there. From our side, we had prepared a chart which is posted on some nursing stations now, because when we designed that chart, nursing stations were few. Then the hospital expanded. Then the hospital expanded in the direction of COVID hospital. Then now it is again coming back. So very few nursing stations have got a chart where we have mentioned what are diluents to be used for commonly used antimicrobials and what is the duration of infusion for these antimicrobials. So if you need it, we can always prepare that again and we can always circulate it. Then whether infusion pump has been calibrated accordingly or not. Then the duration of administration. The duration of administration is again the clinical decision. Whether the patient is improving or not. De-escalation. Which antibiotics needs to be de-escalated? Again, it is going to be decided by the clinician, and you can always play a role. Route of administration of the now, how do we call it as? Let us say some patient is on carbapenem, meropenem, for example. Which antibiotics he can be de-escalated to? If there is a systemic improvement. If we start giving him, let us say, one strategy could be carbapenems, downgraded to piperacillin tazobactam, further downgraded to amoxicillin clavulanic acid. Should we call it as a de-escalation strategy? Or then the strategy will be meropenem, piperacillin tazobactam, amoxicillin IV, amoxicillin oral, then discharge. Is it a de-escalation strategy? Or if we from meropenem again we do not stop all the antibiotics, that is a de-escalation strategy. Why I am posting this question to you is you should have clear idea. Now patient profile differs. There is no hard and fast guideline for which patient what will you call it as a de-escalation strategy. One patient may be on a combination of the drugs. where one drug can be stopped, one agent can be continued, depending on the response. So that could be considered to be a de-escalation strategy. And again, discuss it with the clinician. What is the de-escalation strategy and where there have been instances. Can you believe a patient was continued on piperacillin tazobactam for 35 days? 35 days. Now you ask me how do I know it? Because it is indented from hospital pharmacy against the UHID. That is why how I came to know. I do not usually go to all the wards and scan the files. But from hospital pharmacy, because indenting is for UHID, I came to know that some patient was on piperacillin tazobactam for 35 days. वो खाना थोड़ी नहीं खाया है piperacillin tazobactam. Piperacillin tazobactam उसको खा रही है. So just look at the duration of treatment also. This is again where your role is critical. For how many days the antibiotic has been given. Then again academic interest, purely academic interest, not practical primary as of is therapeutic drug level monitoring. Everybody asks कि vancomycin level कर रहे हो कि नहीं कर रहे हो, aminoglycosides के level कर रहे हो कि नहीं कर रहे हो. So that answer is no, because our HPLC machine is not working. And we need to establish these methods. So these are actually for another critical area where definitely it is your role is very crucial is monitoring for ADRs. Now we discussed something about the ADR profile like QT prolongation, where arrhythmias are a possibilities. Other common reactions which you have reported many times are the local hypersensitivity reactions. Now how we analyze it is whether it is because of the characteristics of the drug or whether it is characteristic of a brand. That means whether levofloxacin or a antimicrobial agent itself can cause hypersensitivity reactions, or it is the brand which is coming in the hospital supply that is the culprit because of quality issues. So we analyze it in different way, and once you have reported these things, we report the same issues to state drug authorities, drug controller, for appropriate regulatory action if it is a quality related issue, not a drug related issue. Another thing which you can definitely play a role is looking at the lab abnormalities. Antibiotic induced thrombocytopenia is a very common finding and often ignored. Yeah, it is. I would say that it is most of the times ignored. Nobody reports that. And bone marrow suppression is another problem. Antibiotic induced nephrotoxicity. You have to remain vigilant for it. And so these are the things where you can always play a role. Now, if you come across any adverse drug reaction, how do you report? Where to report? Where to inform? I will again, हमारा पिछले कुछ टाइम से MCQ से चल रहा था ना सारा कुछ. So if you have to inform about adverse drug reaction, I will give you the choices with multiple correct answers. You need to document it on the patient record. One. Second thing is you need to report it to the resident on duty. Number 3, you need to report it to the ADR monitoring center. And number 4, you need to directly report it to the state national level drug reporting system. Okay. मैंने पहले बोला था multiple correct answers. और fifth answer is all the above. Answer is all the above. करेक्ट. सो अब इतना काम आप थोड़ी ना करोगे, बट आपको तो अल्टीमेटली रिपोर्ट ही करना है ना, एंड डॉक्यूमेंट करना है पेशेंट फाइल में. योर स्टोरी एंड्स देयर. Inform it to the resident, document it on the file that you have noticed it. Rest all things will be done by us. If you want to do, you can be part of that. You can report it directly to us, no problem. Very good. We will be very happy. If you want to report it directly to the National Regulatory Agency, we can always provide you with the link. Upload the information, relevant information. If you have got time, upload it. Nobody stops you from doing that. But the bare minimum that you can do is document it, report it to the resident, and if possible, report it to us also. So this is something where, so that therapy can be modified accordingly. And this was the last slide. As far as I have not gone much into the academics and the theoretical aspects of antimicrobial use, but the practical aspect, look at the route of administration, look at the diluent, look at for how long it has to be given, and please monitor for how long the patient has been on particular antibiotic, the duration of antibiotic use, and look for ADRs.